Hello, welcome to NCGPA Live. I'm Dr. Andy Foster, and I'm joined today by Ankish Patel, who is Head of PCN Workforce at NCGPA, our local GP federation here in Nottingham. Today we're going to be exploring how NCGPA, which has a membership of 40 plus practices across Nottingham City, supports local primary care networks through the employment and coordination of the Additional Roles Reimbursement Scheme Workforce, or the ARRS staff, as we tend to call them, who work in primary care networks. This is the first outing for NCGPA Live. And we hope that local practices and people working or interested in primary care in Nottingham or more widely will find this interesting, and it might have some wider interest for primary care networks or GP federations working in other parts of the country as well. We're aiming to have a fairly free-flowing podcast-style conversation on this topic, which hopefully people will find entertaining as well as informative. So sit back, carry on with your ironing, continue to drive to or from work, or walk the dog, or jog on the treadmill, and hopefully enjoy this and be informed. We're joined by Ankish, who's head of PCN Workforce. Hello, Ankish.
Hi, Andy.
That's great. And just for information, so I'm Dr. Andy Foster. I'm a local GP partner in Nottingham, clinical director of Bulwell and Top Valley Primary Care Network, and I'm also on the NCGPA board at the Federation. Yeah, Ankish, do you want to tell us a bit about your current role and introduce yourself?
Yeah, definitely. Thanks for having me on. So my name's Ankish Patel. I'm a pharmacist, or clinical pharmacist as they're now more commonly known in general practice. So I have worked in community pharmacy for the majority of my career, and then about 4 or 5 years ago switched into general practice, and then started working as a PCN clinical pharmacist. And more currently, I look after the PCN workforce. So I head up the pharmacist workforce, social prescribing, physician associates, and we have pharmacy technicians, health and wellbeing coaches, and care coordinators, and that list seems to be growing sort of every month.
That's great. And how did you come to be in this role, Ankish? Is it by design? Is it happenstance? How did you come to be here doing what you're doing?
Yeah, I mean, you know, with all these things, I think it's there's a little bit of design, and then it's a little bit of right place, right time. So I think after a long career in community pharmacy, working in a variety of like strategic roles and you know, within community pharmacies, where I used to really love, so it took a career change to become more clinically focused, like a lot of the pharmacists that I've moved across. So I moved into general practice as part of the original sort of training pathway. And then in 2019, when the primary care network started, I transferred into my primary care network. And at the time, I thought general practice pharmacist was quite common, not realizing how uncommon it was. But 2 years counts as a lot of experience when the people around you have none. So I started looking after the recruitment of pharmacists, the supervision, and then the role has just grown from there, really. So it's been a really sort of innovative space, which I've been able to sort of fill. So.
Yeah, and it's been really interesting to see how you move from initially managing the pharmacist to really having quite a lot of responsibilities across the whole ARRS workforce, and that's been really interesting to watch.
Yeah, definitely.
So Ankish, you should probably get some basics out of the way, just so that everybody is kind of playing at the same level listening to this podcast. So let's just do a bit of quick fire to make sure everybody is at the same place in terms of their knowledge. So just for those people, probably not many of them listening, who don't know what a primary care network is, just very quickly, just say what that is when we're talking about primary care network.
Yeah, so the originally created in 2015, but in 2019, a new contract came out, and it was all around working at different scales. So rather than practices working individually, there was a contract which allowed groups of practices to work together within a geographic area with an approximate sort of patient list size of 50,000, but not limited to that. We've got networks that are under and over, really. And the basis of that change was to look at how we can affect population health inequalities at a more broader geographical level, rather than working with individual practices, working with groups of practices. So.
Yeah, absolutely. And of course, a big part of that was the introduction of the Additional Roles Reimbursement Scheme, which enables practices through primary care networks to employ certain specific additional roles to work across that group of practices to provide sort of value and care and support those practices and support the populations. And that's what we talk about when we're talking about ARRS, bit of a tongue twister. That's the Additional Roles Reimbursement Scheme, isn't it? Ankish, what sort of roles are included within that? Because it is quite tight, isn't it?
Yes. So it was really tight at the beginning. And then obviously there was a lot of pushback from general practice to say, actually, we need more than what's being offered. And the number of roles seems to evolve every year. And there's always changes and additions. But there's a big scope. I mean, the primary roles being recruited over the country are social prescribers and pharmacists, which were part of the original contract. But like we said earlier, we've got health and wellbeing coaches, podiatrists, dietitians, chiropodists, pharmacy technicians, mental health practitioners, advanced practitioners. So there's quite a comprehensive list of roles which can be selected for your PCN. So
yeah, and it's always growing. I'm always scared of missing a role out and offending people.
I've definitely left occupational therapists out there, and there's paramedics. I sort of cut it short, but there's a really wide range of roles. So.
Yeah, apologies if your role is on the list and we've missed you out. Everybody is welcome and everybody is valuable. And of course, it's quite sort of specific how the funding for those roles sort of flows as well, isn't it? With funding coming to reimburse for the full employment of most of those roles, coming down through primary care networks to employ and deliver those roles. I remember having some sort of conversations at the beginning with colleagues who we often want to say, "Oh, can we use the money to employ, another practice nurse to work across the network, or locum GPs to support practices?" And of course, there are things that are on the list, there are things that aren't on the list, and that kind of limits in some ways what's possible. But of course, those roles can be employed in the traditional way through practices. So I suppose the final piece of the pie here, Ankish, is so what is NCGPA? So we're a local federation, broadly speaking. What's NCGPA?
Yeah, so I must say there are care coordinators as well, because there's a couple of people that won't forgive me for missing that. So, and I think when you mentioned that bit earlier, it is about additionality. I think that's really important. There are additional roles. They're new to practice, but the NCGPA is a federation in Nottingham City, and we represent the vast majority of practices in the city who are our members essentially, and we provide functions for them at scale basically, and that's how we were involved in supporting them with the delivery of primary care networks, and particularly their employment situation. So
I guess so what role does NCGPA sort of currently play in the employment and delivery of the ARRS staff? And I suppose we can rewind to the setting up of primary care networks just to think about how that came to be as well, I guess. So tell us that story, Ankish.
Yeah, definitely. So at the time I was working in extended access within the federation as well, because that was a service we were providing, which was for the practices in the city. And when the contract came out, I think the main reason why we were involved was this question of employment liability. If networks to employ staff, and one practice in particular will employ members of staff, are they willing to take the liability of risk for the rest of their practices within that network? And that's where we became a natural solution for that, because we were already delivering things on behalf of the practices in the city. So we were involved in the employment. We had the recruitment structures in place, and so on, really. And we already had some experience of the pharmacist roles as well. So we had at least a little bit of background with regards to one of the roles. So we currently, sorry.
No, I was just currently,
at that early stage, we were very much just recruiting the staff, employing them, and then providing supervision, which means a lot of things to many different people. So.
Good. Yeah. So I think people might notice there's perhaps a little bit of a lag here, isn't there, which might produce a tendency for us to speak over one another. We'll be very careful around that, but I think that's what people just heard, if that sounded a little bit strange. So I suppose that was what was happening at the beginning, and how NCGPA came to be involved in the delivery of the ARRS roles. And what does it currently look like, essentially?
Yeah.
What's the current shape? What does it look like? What's happening?
Well, it's huge, isn't it? I think when you look at the fact that what we're talking about there is 2 years ago, and in 2 years with a global pandemic, we've gone from having 4 primary care network staff to nearly 100. So we have nearly 50 pharmacists, coming up to about 10 pharmacy technicians. We've started a new role with regards to physician associates, where we went from 0, we're now up to 14 within 6 months. We've got 24 social prescribers. So we're really sort of pushing out and moving into care coordination, health and wellbeing coaching. So real expansion in a lot of those roles. I think what we have seen in the city is this belief in having a critical mass of one role to be able to really have some delivery around it. And that's why we've seen such large numbers, especially with the pharmacy workforce, where because it's been in from the beginning, people are starting to understand what it can deliver and they want more of it. So.
Yeah, I'd certainly reflect that, Ankish, because I know thinking at kind of a local primary care network level, there's a lot of work that goes into bringing online a new role. And the more discrete roles that you have across the primary care network, the more sort of energy and resources are required to get value from each of these roles. So I think a lot of people are learning that actually it can be better to double down on the roles that you've already got and that are delivering value. And if you are exploring a new role, to be sort of very clear about what you're doing and why you're doing it, and that you'll get value from it. I think that's a trend that I've seen emerging going through. But yeah, huge numbers now. Really,
Definitely.
really impressive.
I was going to say a clear example of that is around induction. When the first role started, I remember when the pharmacy started, I wasn't actually managing them. I was just sort of leading, which is my sort of role in a way. And their induction, some of them covered 8 sites, on their own. I think within your own network, we had a part-time pharmacist covering all the practices. So for those staff to then induct other staff, they know everything about what a good induction is. And they're the sorts of things that we're starting to benefit from. People that have been in the post for 2 years can induct a new member of staff within that role really, really well. We'd never be able to achieve that quality of the induction 2 years ago. So.
Yeah, absolutely. Yeah. Those first inductions and posts were really quite difficult, and there was a lot of learning going on, getting it right with those first employees. I certainly remember back 2 years to those times. So I guess just to make it sort of real for people out there, before we go a bit deeper into the lessons that have been learned along the way, I was just wondering if you could give us some examples of kind of what some of those ARRS staff are kind of doing on the ground for their practices, their patients, their primary care networks.
Yeah, so we'll start with pharmacy, because that's obviously the closest one to my heart. I think the pharmacist journey has been interesting. I think there's not been a lot of targets for us. I think early on, there was some things in the impact and investment fund around med safety. And I think our primary role over the last 2 years, from my point of view, has been to focus on practice integration. So on a day-to-day basis, we are delivering structured medication reviews, and we have protected sort of times for those. They do tend to take 30 minutes or longer for complex patients. We look at workflow, we look at discharge, we look at tasks, we look at MHRA alerts and safety. So it's quite a comprehensive role, but it's very specific to individual practices, depending on what their needs are. And those roles are starting to evolve now into more specialist areas around diabetes and other long-term conditions, and leadership and mentoring and coaching. So there's a variety of different roles there. The social prescribers themselves, we started off with quite a small workforce that's now expanded to 24. We've got coming up to 24. We've got 5 to 6 social prescribers in some of our PCNs, and we're starting to move into more areas of proactive referral rather than just waiting for referrals to find the patients who most need our help. And they have been involved in weight management services. We helped with the booking in of patients requiring COVID vaccination, and we're out creating walking groups, community events, and we've recently bid for some centralised funds, which we'll be able to use to help our patients more directly. So really, sort of evolving model of care there, which is really fantastic. So physician associates, we're looking at home delivery, home visiting service, care home reviews, but we're really early on in that journey, to be honest with you. And we provide preceptor training, and we're sort of educating them and training them every sort of 2 weeks to support that journey. But the impact of physician associates has been incredibly successful. It's been really good, and we did things a little bit different there. I think we'll probably come on to that a little bit later. But when the physician associate roles came on, lessons learned, we insisted those people be kept in only one practice or a maximum of 2 for the first 12 to 18 months, which is very different to our previous ways of putting a full-time pharmacist across 8 sites. And that level of stability shown a really good return on that investment from those practices. So,
absolutely. I was just wondering if you could say a few words about care coordinator role as well, because
yeah,
that
so
appears to be one of the more sort of versatile roles in a way. And I'm hearing lots of different PCNs deploying those to roles around care homes, for example, but also, safeguarding, lots of other things. Anything to say around those? Because that's been really interesting to me.
Yeah, very interesting. I think it's a broader scope of all the roles, and I think we've got safeguarding coordinators in care coordinators that have been doing a great job. We've got 2 of those within one of the PCNs, and we're looking to really expand that. We're hoping as an organisation to have a single point of access, because we want patients to be able to access additional roles and citywide services in a slightly different way, and not just be reliant on a GP practice referral. So that's quite interesting, and the processing of those referrals and the support and signposting given to those patients is going to be helpful. We're also looking at how care coordinators can support each of the roles individually as well. So we may have a pharmacy care coordinator, which is helping, I wouldn't say triage, but in a way it's about filtering and making sure that the most appropriate patient sees the right role. And it's all about the right care, right place, right time. So we're really moving into that space of making sure that we make the most of roles and their specialisms, and the patients get to the point in the right place in the system. So, but a real, in other areas, I know the care homes are being supported, but I think it's a real exciting space with lots of potential for growth. So.
Yeah, the whole area is really quite exciting. It all represents a real injection of genuinely new money into the system, and new staff and new roles. So it's a really exciting space to be working in. So
just one last, the health and wellbeing coaches as well. I should definitely give a nod to them. That's another area that we've just moved into, and we've got different models. So we've got one health and wellbeing coach who's very much in practice, clinic every day, different practices, and we've got groups of health and wellbeing coaches in other sites who are delivering community-based exercise. We've just had a grant for exercise equipment being approved, and we're looking at how we can deliver interventions more proactively within the community and be able to engage people in a slightly different way. We have yoga groups for like Muslim women in one area, and we're trying to work with practices and look after our health and wellbeing of our practice staff as well. So
yeah, we really could do an episode on each of the ARRS roles, and maybe that's something that we'll do in the future with NCGPA Live, and get some of them on to talk to us. That might be of interest to people. So just moving on to the next area to talk about is just touching base on the lessons that have been learned over the few years that we've been doing this at NCGPA, because it's not all been smooth sailing, and this is a completely new area. So we can't really be expected to get things right from the get-go, I guess, or do things as optimally from the start. So what have been some of the areas where lessons have been learned over the years, Ankish?
Definitely, I'm really glad this is part of the podcast. Really, I think we do away days for our staff, and I remember we had a really senior GP well, he wouldn't call himself senior, but a senior GP. He came to our pharmacist away day, and right at the beginning of the meeting, he said, "Actually, you know what? To the pharmacist, you are at the beginning of a long journey. 2 years in, it's really early. You are pioneering a new way of working, and in 5 years, you'll have revolutionised parts of primary care." And I always try and remind everyone about the infancy of primary care networks, federations providing the staff and the staff themselves. So, and when you have such big change, you will learn a lot of lessons and make lots of mistakes. So I think it's important to reflect on them, really. So I think the first lesson for us is the one around don't spread staff too thinly. Very early on, we learned that actually, if you bring a new role into a new setting, how do you expect a member of staff to have any impact when they have to engage with, let's not even talk about 4 different practices, 4 different staff, 4 different ways of working, and then actually grow a role that no one understands? That's impossible. So, we're thinking about the pressure we put on individuals when they come in and the support that they require. Isolation is really, really important. New roles are very isolated, and I think that's where, as a federation, we've really excelled. Our retention within our pharmacists is I think second to none. I think we've only lost a few pharmacists along the way, and that's due to promotions or personal reasons for businesses and things like that. So I'm really proud of that aspect, and that's probably been the biggest learning from the journey so far. And the supervision model we put in for our pharmacists, we've rolled out to the other workforce within the ARRS workforce, and it's really well appreciated. They all talk about it as an absolute sort of anchor for them within, when there's so much change and so much to learn. So
yeah, I'd certainly echo your comments about people being spread too thinly early on. And I sometimes thought that actually, if you were designing a role or a job deliberately to stress people out, you'd make that a new role that no one's done before, that no one understands, and give them 4 to 8 different organizations to work for and across in 4 to 8 different physical locations sometimes, and give them multiple bosses, and that's just a recipe for making people stressed without managing that in the right way. So it's good and necessary that lessons were learned about how to handle that better, really. Yeah, are there some other areas in which sort of lessons have been learned in the rollout of all of this, Ankish?
Relationships. With so much change, it's really difficult to let everyone know what's going on. And I remember one of the local clinical directors, Margaret Abbott, she just said to me, Ankish, just because you've not finished what you're trying to do, don't not tell us what you're doing. And I think when the pace of change is so much, it's really hard bringing all of your stakeholders along. And it's very hard to consolidate that and the information. And I think what we've learned is just to slow down. It's okay to say no to certain things, and let's do what we do well and still push out the boundaries. But the communication thing is an ongoing challenge. It's really tough to be able to communicate to 8 primary care networks, 42 practices when there's information overload, and it was quite interesting early on within year one. There were practices that probably would never have looked at the network the direct enhanced service contract, and why would they? It's not always relevant to a practice when decisions are made at strategic levels, and suddenly a new member of staff that they don't know about suddenly turns up in their practice. So all those types of things we're learning to engage with the system in a slightly different way. So we're all moving together rather than people trying to catch up. So
yeah. I know, Ankish, one of the things that I've heard you talk about before is sort of the tension between the different levels at which you can operate and structure things. There's the practice level and structuring things around that. There's the PCN as a whole. Some things might be better done from an economies of scale perspective, across a city level, or organized across the city level, or even greater. How have you been navigating those tensions?
Yeah, so not always very well. It's quite easy to just upset the equilibrium when things like that happen. So I think what's important is that the system has to be represented, but it's recognizing that this way of working is about our neighbourhoods and our patients. And I remember with the social prescribing service early on, before I was involved with it, it was a citywide service, and that ticked a lot of boxes for people because it's easier to refer into a citywide service. But actually, we need to be responsive to our needs of our patients and our local neighbourhoods and our demographics. And Nottingham City is I think we're the 13th, most deprived area within the whole country. The life expectancy range is over 13 years difference by walking less than, you could walk less than half a mile and have that type of disparity. So we need to be responsive to our local areas. So that was quite a challenge, moving from a citywide social prescribing service to making it very PCN specific and reactive to our local population. But I think, again, it's all around making sure that we engage people. So I think we spend a lot of time and are spending time to make sure that the people we employ represent their services. So our lead social prescribers will come together to share, to collaborate, and they will represent the social prescribing service within the system. And that allows other agencies to engage with them. And we do the same for the pharmacists. We will be doing the same for the health and wellbeing coaches. So at every level in the system, we've got representation, basically starting from the workforce that's delivering the care and the change, working all the way up into the ICS. So,
good. And you'd mentioned sort of partnerships there. And I know one of the things that I've seen happen is that people are becoming sort of more and more aware of the opportunities to partner with other organizations, across the city, or the local organizations, or the council or third sector, or commercial organizations to deliver things. Have you got any examples of partnerships, or have you learned anything, about partnering up?
Yeah, definitely. I think we've partnered with private pharma, and sometimes people look at that and go, "Oh, healthcare, private pharma." But the ABPI rules have been relaxed to allow collaboration and the ways of doing it with good governance. So when we partner with them, we involve our local medicines management team, the CCG, and their governance structures within there to allow that to happen. We've worked with other firms to support the way that we interrogate data. And we're looking as we go forward for how companies can help us support with the IIF, so we can get on with helping the patients and maybe not necessarily doing all the searching. So we're always looking for new ways of working. I think one of the other important parts for us is that we need to retain our workforce, and we do that by thinking about roadmaps for our careers and future. So we're very big on trying to develop them and create new roles. And those new roles are based on the needs of the patient. And quite often they involve bridging the gaps between our mental health trusts and secondary care and other agencies. And that's very much the space that I'm looking at, how we can really evolve and adapt to the needs of our patients, and then create the opportunities that are needed to meet those needs, rather than just create roles because they match the needs of individuals sometimes. So, yeah.
Yeah. And just listening to some of the concepts and things that we're finding are required there, it's just striking me that some of those things feel best done at a city level. It strikes me that it would be difficult for the 8 individual primary care networks to liaise with local medicines management about different projects and so forth. So there seems to be something about doing the right activities at the right scale there. I wonder if that's something you can speak more to, or...
Absolutely. I think one of the absolute one of the things about my job, which I didn't fully appreciate a while ago, is the fact that I can see the whole system. I can see all of the primary care networks. We help facilitate those lead groups. So we're getting the intelligence directly from our care coordinators, from our social prescribers, from our pharmacists. Some of the PCNs want me in their development space as well. So I'm more than happy to do that. And so it allows me to be able to see what's needed and where things can be, we can deliver at scale, and where we can look at maybe sort of slightly differently innovative solutions by using, especially the ARRS funding that's there, to be able to deliver different types of working. And from my experience, PCNs are really keen to work together. The one thing I always get asked is, what is that PCN doing? And I think that being able to open up that level of sort of transparency and that collaboration, I think we're not quite there at maybe at a clinical director level, perhaps, within the system. So I think it's starting to filter through. But I think from my point of view, if we can build it from the ground and get the staff doing it already, it's starting to set things around the needs of the patient. And I think that's the way forward, really. So the challenge of that is the intel. So quite often, you mentioned relationships as a challenge. We can be on the outside of conversations. Sometimes we're not always privy to what's happening within the primary care network. And I think as we go forward now, how we integrate with our primary care networks and the CCG and the ICS and those other organisations is going to be really, really important for our effectiveness in the space. So,
and you spoke in there somewhere about the complexity of bringing on a new role, and I know something that's quite new to a lot of us is physician's associate role, at least in Nottingham. I mean, it's quite a new role in primary care, and I've seen some very innovative things happening. Not actually in my own primary care network. We stood back a little bit from physicians associates, acknowledging that it might be a complex new role to bring on, and potentially a little bit controversial in the mind of some GPs and some, advanced nurse practitioners and people who operate in a similar space. But what's been the approach to bringing physicians associates in Ankish?
A measured approach, taking a little bit of time to absorb the lessons learned nationally. So, and tapping into resource that's available out there, that's being paid for. It's not always easy to be aware of what's happening nationally, and that is a criticism of sometimes how things work. But I think myself and one of the clinical directors took a little bit of time and space to really understand what was working well in other areas and not reinventing the wheel. Taking the best of the principles of where the service is working well and bringing it into our space. Took time to speak to their faculty and their leads and really tapping in and using LinkedIn, I think, as a platform to connect to different people and different leads and professors and universities. It's a really, really good tool, and people are quite generous with their time. So we took all of that and we built a model. We knew that we wanted to lead within the service, so it took the pressure of supervision away from some of our clinicians and the leadership around it. So we built the model and then presented it back to clinical networks, and then they decided on who wanted to be part of it and not. But it was the first time we sort of said, if you're having this role, it needs to stay within no more than 2 practices for 12 to 18 months for us to allow us to establish it. So which was really important. So
yeah, it's been really interesting to observe how the lessons are learned each time a new role is designed and brought on, because how the physicians associates were deployed is very different to, say, the social prescribers, which were one of the first roles. So it's just really interesting and quite reassuring in a way that things are done differently, and that things are learned and new things are tried.
And this investment in supervision, in training, pastoral support, that's how you're going to recruit people. There are recruitment challenges out there. We never struggle to recruit pharmacists because we have something to offer. We have stability and long-term roles and changes, and we had advocates within the service. So I think you have to think about how you attract people. When we started the physician associate model, because we were offering the lead person there, we've had people move. We had 2 people come from Manchester, people from South Staff. So people have moved into our city, a deprived area of the country. We've got a movement of professionals coming into our space to help, enrich our sort of local population. To me, that's really, really encouraging that people want to do that for the right job. So
yeah, that is so powerful that people are actually moving city to come in and work within our primary care networks. That's really, really incredible, really. Ankish, something I've been wanting to ask you a little bit more about is the sort of academy concept, which I think you've grabbed me in corridors and tried to tell me about this in the past. But here's a bit of space to tell me and more people about this concept.
Yeah, well, I'm really glad COVID lockdowns are a bit more reduced, so I can have those corridor conversations and share ideas and get a bit of feedback on stuff. I've missed that. So basically, I think it's based on some of the principles of like the PAs and stuff. So we're hoping that there's not enough supervision for roles. Our GPs are under so much pressure, and so are some of the other roles to be able to support. So the concept is that perhaps we use practices or networks to develop roles. So for instance, for a physician associate, I think that the concept around it is that one of our practices could become a training academy. So if your practice would like a PA, we'd discuss with you what you'd want from that PA, and whether it's home visiting or care homes, decide on what the minimum sort of competencies you'd want them signed at, or what level you'd want them at, if you could ideally have them come into practice, and then we'll train them within that practice space. And within the practices we use, we'll keep our more experienced PAs. We'll bring in the trainee PAs, so we're increasing capacity within those practices by as a return for their support. And it's a cost neutral way of training staff up and having them at a minimum sort of spec or competency level before they come into general practice and within a primary care network. So I think it's a way of thinking about how we develop staff slightly differently and really give them a lot of intensive support at the beginning. Because when we look at our workforce, and when I look at them generally, like the ones that have had much better supervision, much more time with clinicians, and had much more time invested early on, are moving at a much faster rate now. It's like an exponential growth, the people that want to move into primary care networks. And if you put in the investment early, there's a lot of reward in the medium to longer term. So
Just got a question about that concept, Ankish. So that academy model involves staff, say physicians associates, spending like quite a long period of time, at one practice within a primary care network, and by virtue of that, I guess, not the other practices. And I'm just wondering if that's introduced tensions between the practices, about an inequality of the distribution of that ARRS workforce, because certainly early on, those were the sorts of tensions that I know we were experiencing across the city. How's that been experienced and navigated?
It's been okay, actually. Maybe I've not heard some of the feedback, and there may be some things that I probably need to listen out for a bit more. But I think there was, when we went out and explained the needs and the training support that a physician associate might need at sort of F2 and like with regards to the support they might need, we wanted to somehow return the time invested in that early intensive supervision back to practices. And I think on that basis, quite often, practices that could not offer supervision or did not have the GP capacity to do that did not put their hands up. And they were quite happy for this model to happen. I think now what we're seeing is physician associates, we've got one practice who wants a second one. Practices that took them part-time, so they might have we covered 2 sites. All of those practices want a full-time PA, so it's starting to evolve and be able to support, but the feedback was quite positive, really. I think there was an understanding that if I put my hand up for this was the model. And as long as you know what you're getting and these are the rules around it in a way, then people are happy because they understand this is what's been presented, and you understand that you could have had a PA, and if you still choose to, we'll go and get you one if the need is there, and the same model will work for you. So
yeah, no, I think it's that clarity of the situation and that equity of opportunity, I guess, to get involved, which seem to be like the positive features that have allowed for successful navigation of that tension. But that's a really interesting lesson. So we reflected on some of the challenges when we were talking about just the lessons learned and the journey along the way, but it's just an opportunity to highlight if there's been any other challenges, that you've observed or that you've experienced going through the delivery of these roles.
Representation. As a pharmacist, not always welcome within some spaces, I would say. There are still some unhealthy sort of power dynamics sometimes within primary care. So as a pharmacist coming with a community background, sometimes that some doors are sometimes closed, etc. So it's been a challenge breaking some of those barriers down within the system. But I've really enjoyed that challenge. But when things are new, that's going to happen. Some of the other challenges for me as well, because I started in a practice where I did my training, we're seeing this emergence of like a 2-tier workforce. It's great that PCN staff can come in and they're employed by federations, and their terms and conditions might be different, their rates of pay might be different, but they're also getting a lot more supervision from our point of view. And I worry that the standard that we're setting around supervision for our staff, and we have group supervision for pharmacists 4 hours a month, the social prescribers have 4 hours over 6 weeks, and the health and wellbeing coaches, etc. We have a wellbeing session for our social prescribers because of some of the pressures they're under with regards to mental health. That should be available to all of our workforce. It needs to be, if we're able to recruit and retain and have a happy workforce to the level that we are, then for me, it needs to be the standard for primary care, not just for one group of people. And I do worry about the levels of support and training and education. Quite often with the pharmacists, this has always been sometimes contended with some of the nurses, for instance, that may have been waiting for independent prescribing qualification and support needed. And then pharmacists come in, they get 28 days of training over 18 months. They then get a designated medical practitioner appointed to them, their prescribing course paid for, the supervision needed to do that. And suddenly we've accelerated roles at the expense of others potentially. And I'm not sure we've quite realised that and what we need to do for our existing workforce.
Yeah, I'm really glad you've highlighted that, actually, because that's a tension that I observe as well. You've spoken to a lot of the dimensions that takes, but often people look at the length of appointments, for example, that some of the ARRS workforce might have compared to so we look at sort of a structured medication review and 30 minutes for that, and the GPs will say, well, we get 10 minutes and we're reviewing the medications and we're dealing with, multiple problems as well. And, there is some truth in that. But I know a structured medication review is very different to the medication review that a GP would do. But I just give that as an illustration of the sort of differences between
I think,
people.
yeah, I mean, I have to come back on that one as a pharmacist. So I
Of
think,
course.
we've always had that challenge. And I think, actually, the only way of fully understanding the delivery of why that is different is through the appropriate debrief, and I think early on when I came into my role in the practice, my GP, Dr. Jones, who was at Grange Farm at the time, just said to me, do not come here and do what we already do. And that's the first thing she said to me on day one. So you've been employed with your skill set and you're going to learn from us and we're going to learn from you, but you need to bring what you know about. And without any disrespect to a GP, I've trained in medication for 5 years. By the time I've done my prescribing, that's another 9 months. By the training, the education pathway, our primary care pharmacists that are working within practices have done nearly 8 years of training to be able to be at that point. And we are experts in medicines. And I think when you start looking in, hopefully, like when Alistair said, we'll have revolutionized some of the aspects of primary care. Hopefully we start seeing some of those impacts of medicines related admissions and harm and reduction and stuff. And I think actually a structured medication review is very different to what was being done before. And the reason we're here is because the old system didn't work, and we're bringing a different approach and a different angle to it. So, but it worked in pockets, but not consistently enough to improve the safety of medicines. So,
yeah, I'd agree actually, and I think spending some time debriefing one of the clinical pharmacists after they've done structured medication reviews is a really good experience as a GP actually, because you get to see the sorts of things that they have time, and the expertise to consider, the sorts of questions that I'm asked about. Does the practice, consider these particular drug interactions, or are you, what's the practice policy on monitoring the renal function with regards to this set of drugs? I'm not talking the ones that we're already, well versed in. I'm highlighting that they ask some questions that are really, really useful to actually tidy up practice policy and really, really help individual patients get safer prescribing. And these are things which the system just hasn't provided time for before. It's not that GPs could get skilled up in these things, and if GPs had more time, they'd probably be picking these things up as well. But the system just hasn't afforded that. And now the system has through the structured medication review, which is positive, I think.
Yeah, I think a little bit of a gap as well is that evaluation. I think what's really keen for me is to not get stuck in the metrics of how many tasks we've done or workflow, etc. And this is across the roles. Like, we have to start bringing back qualitative examples of how we've impacted patient care. And then we want the system to be able to look at the data around medicines harm or social interventions or the impact of setting up a group in certain areas. So I think we've got to focus on the quality, and we're here to focus on that quality. And I don't think the system we've not quite caught up on, as ARRS roles, on how we report back to our practices and our networks of what we've achieved so far, but we do need to stop and consolidate that. So,
absolutely. There's some really good highlights. The two-tier workforce, that really is a challenge. Before we move on, I just think, that if we look at sort of care, say, let's take the care coordinator role, that's a role that might be similar in some respects in terms of its contact with the general public to a receptionist, for example. But they get quite a lot of opportunity for consolidating learning, supervision, talking about difficult experiences. And the receptionists, bless them, are just on the front line every single day. And because it's an old role that's been around since the beginning of time, or the NHS, no one's ever thought to build that sort of thing into their role. And they'd really benefit from that. And the public would really benefit from better supported, better trained receptionists, for example. So I just hope that both as a local system and local practice, we can learn from that, but that also the NHS in general and Department of Health can learn from that as well, and maybe introduce more support for everybody. Ankish, what have been some positive highlights then, just in terms of you acting in your role with NCGPA, working with the ARRS workforce? Any positives?
I just love I'm given a lot. I suppose I'm given a fair amount of autonomy to go and work with the staff. So I absolutely love the supervision aspect. So I'm actually with the NHS Leadership Academy as a training as an action learning set facilitator. So I'm a 2-year sort of end of journey for that, and being able to bring those aspects of that into supervision. It's all around group problem solving, around coaching others and stuff. So I've actually loved taking all the principles of action learning and starting to embed them into our supervision models. That's been really exciting. So I think the other bit is just initially my when you talked about how did this happen, how did I end up in my role? Well, when I moved, I had ideas of what I wanted to do, and I was very much there to represent my profession, get pharmacy, really make sure that we're able to have an impact and be accountable and be present, and and really represent our role and promote it. But I think for me now, my role is around trying to help the patients in Nottingham and how this workforce is going to help improve healthcare. So for me, I just love that my mindset's a little bit different now, and I'm really looking at how this can really help patient care. So that's really exciting. So and then the projects we've got coming up, that I think it's really exciting for me to be able to create new roles. We've just started doing some training at the University of Nottingham for pharmacy students on System 1. We're looking at teacher practitioner roles and split roles with learning disability and mental health, and really looking at how service provision can sort of change within primary care networks. So I know there's probably not highlights, but I'm always looking forward. So I'm always looking for things that are going to be exciting in the future. So.
Oh, fantastic! It's great to hear that you after 2 years and number of challenges in delivery, that you're still so passionate, enthusiastic. That's really good to see. So just moving on to the one of the last questions that we've got queued up for you today, Ankish. Additional roles reimbursement scheme and the future. Is there anything that you see on the horizon that's exciting for you, or you think has lots of positive possibilities?
Yeah. So 2024 is the number that I have in front of me, and when I'm sat with some of the primary care networks and the clinical directors, and we're looking at workforce, it's very much thinking about what we want this workforce to look like at the end point. So if we're looking at the pharmacy service, what does that look like at the end of 2024? And then let's fill the gaps for the recruitment. And more importantly, if we're looking at the health inequalities in your area and on your patch and in your neighbourhoods, what type of services do those patients need? What do you want it to look like in 2024? And let's start filling the gaps. Very early on, I always likened the recruitment of PCN staff to like supermarket sweep. It was this whole bit of, you could have whatever you wanted, throw it in the trolley with no idea of what we're cooking recipe-wise. But now we do know what we want to cook. We do know what the outcomes we want with regards to the health inequality data is. So let's really be focused about what we want. And then it allows a bit more control over what we need to get and when with regards to the recruitment strategy. So.
Absolutely, I agree. And there's a lot more clarity from the system in terms of the IIF markers and the other elements of the DES that have been fleshed out. So we know more what we want or what we need now. So I appreciate that. And it did feel a bit haphazard initially, didn't it? As you say, I love the supermarket sweep analogy. That's really powerful. So I guess we'll start to wrap things up now, Ankish. So I think we're going to ask this question to everyone at the end of these NCGPA Live episodes. What can people do next? What's the call to arms, as they say, if people want to know more or they want to take action on some of the stuff that they might have heard? What can people do?
Number one, I will make myself available. You can contact me through LinkedIn, and there'll be some contact details afterwards. So LinkedIn's been really helpful to me when I need to find out about stuff or contact people that I may have a specialism in something. I can reach out, and I think that's the important bit. Connect the dots. We've come out of a 2-year bit of craziness, really, where people aren't talking and those meetings over coffees in corridors aren't happening, and there's a lot of people that are isolated. There's a lot of work happening in isolation, and sometimes it's duplicated and they're not working together. So I think it's all around having people around you that are looking at the system and are driving the system to communicate and collaborate and share and support. And it's that, for me, that's a number one focus into this next phase, really, of looking at what we've got and getting it to work together better. So.
Absolutely. So that's great. I think you've alluded to how people can get in touch with you. I guess if people want to work in Nottingham, or work within a primary care network, that's inclusive of those people as well as people locally who might want more information about the ARRS work and how to get involved. And I would say I think people can approach their local primary care network. If you're working in a practice or an area, find out who your social prescriber is, find out who your clinical pharmacist is, find out who the other ARRS roles are, and start to talk to them about their roles and get involved and talk to your clinical director, deputy clinical director if you have one in your area, about how to get involved with the primary care network if that's what you want to do, having heard this. So I think we've got a final slide which I think will contain some contact details. If not, we'll put one at the end of the recording. Any final word, Ankish, before we leave?
No, I think that's it. Thanks for the opportunity to talk about this. I'm so always happy to help others and share. I think the more we do that, the better. So it was really, really good sort of talking to you today. So I look forward to maybe doing it again.
Yeah, fantastic. Thanks for joining us. And thanks to Maisie, who's in the background, sort of helping coordinate this episode as well. So let's put up the final slide. And, hopefully people have enjoyed listening out there. Do feel free to get in touch with any of us and NCGPA as an organisation or your local primary care network. And hopefully we'll do some more of these videos with some more sort of characters and people from NCGPA, primary care networks, and the local health sort of ecosystem and economy. So thank you very much. Goodbye.